Yeah. Good evening, friends. Okay, you've heard my spiel about sponsors, and I don't need to say that again because you've been here practically every night. And have you taken the survey yet? The pressure's on? Okay, so this is the little, I'm just going to grab this. This QR code takes literally 90 seconds. We want to hear from you, so please do that when you have a moment. It is about what you want to see the library doing for the next 3 years, what you want us to focus on. Okay, and silence your cell phones, please, and join me in welcoming Kaylee. Kaylee Boyson-Quinata is a licensed marriage and family therapist and AAMFT approved supervisor. She received her master's degree in marriage and family therapy from Edgewood College in Madison, Wisconsin in 2012 and has been practicing therapist ever since. She's received specialized training in child-parent psychotherapy, a counseling method focused on attachment and healing parent-child relationships after exposure to trauma or violence in childbirth, birth to age 6. She's also received additional advanced training in perinatal mental health and solution-focused therapy. Her passion is helping parents understand their young children's challenging behaviors and teaching them new tools and skills to connect with their children. In addition to counseling, Kaylee is a certified positive discipline parent educator and enjoys helping parents and professionals enhance their skills and knowledge through speaking engagements or workshops. She's spoken at conferences and other events on topics such as leadership, family therapy, engaging parents in treatment, and positive discipline. In her free time, do you have any free time? No. She enjoys being outdoors and spending time with her children, dogs, and spouse. What kind of dog do you have? 2 corgis. Corgis. Okay. We love corgis here. Yes. So please join me in welcoming Kaylee Boyson-Quinata.
Thank you. Thank you for that nice welcome, and thank you all for being here. I'm really excited to talk to you all tonight. So, and yes, spending time away from the corgis and, and children. So it's always worth it to share information with people. So I'm going to talk a little bit tonight about navigating trauma and understanding the impacts of trauma on maternal mental health specifically. And in relation to the book, I'll reference it a little bit. I'm sure you all have read it, but kind of understanding how a traumatic event like that might impact someone and impact an infant as well. So like Nancy said, I'm a licensed marriage and family therapist. I'm the owner and director of Family Roots Therapy. We have 2 locations in Portland and 1 in Tigard, not too far away from here. And I've specialized for most of my career in early childhood, so birth to 6, and perinatal mental health, which I kind of view as 2 sides of the same coin. I don't think they can truly be fully separated. So really, if you're treating one, you're treating the other. And that's a little bit of what I'm going to talk about today, too, is that the mental health impacts really go both ways, and you can't, I think, fully disentangle those 2. So why are we talking about this tonight? It's a very important topic, and there's quite a bit of prevalence of trauma in this country and in the world. Approximately 90% of Americans are going to experience a traumatic event at some point in their lifetime. That doesn't necessarily mean that they're going to develop something like post-traumatic stress disorder, but many, many people experience some form of traumatic event. Between 10 to 12% of women develop post-traumatic stress disorder or PTSD in their lifetime. And those rates are going to be much more elevated in populations that are low income, people who are a racial or ethnic minority, and in urban populations. So there are some populations that it's going to be quite a bit higher than others. And I found a really wide range of rates that were listed for pregnant women. So as I was researching this a little bit, I found rates from 3 to 18%, which is a pretty big window. So I'm not sure where in there that truly falls, or I didn't get to do a deeper dive into why that's such a big range, but I did find as high as 30% in some of those higher risk populations. So pregnant women in particular do tend to have some higher rates of PTSD as well, and we'll look a little bit into how that impacts them and how that ultimately impacts infants as well. It has a big impact on the pregnancy, on infants. Pregnant women who have PTSD are 35% more likely to give birth prematurely. So often that looks like I'll go a little bit into some of the impacts on health, but often can impact the birth as well. So I just got a little bit into why this is important to understand. But one of the big reasons is that when we're looking at trauma in women, we're also looking at an increased risk for children. And so the women who have had psychological distress during pregnancy, the risk increases quite a bit for their children experiencing mental health symptoms. So kids are more likely to show ADHD symptoms, aggression, what we call externalizing behaviors, which is behaviors that other people will see, such as being maybe more hostile behavior, aggression, things that kids tend to maybe get in trouble for, versus internalizing behaviors are more self-focused and internal, so ruminating thoughts, negative thoughts, things like that are more internal. The externalizing ones are the ones we can see from the outside. I found it interesting that this effect even held true when we're accounting for postnatal distress. So even if we're kind of controlling for distress, okay, maybe if there was distress during pregnancy, it's likely that there's still distress after pregnancy. Even when we controlled for that you still see that impact on children after birth. And that this effect was largest during early childhood, but it was still present even in older children and even into adolescence. So this can be a really long-term impact for kids. The theory right now is that the stress hormones are impacting a child's development during pregnancy, and I'm going to go into that a little bit of what those stress hormones are. The main one that we're talking about is cortisol. Maybe you all have heard of that, and that's been something that has been around or people talk about quite a bit. So when we're looking at the stress response system, what we call the HPA axis, it's what alerts us to a threat and allows us to respond appropriately to a threat. So in a normal circumstance, we might have some kind of threat. Maybe a long time ago that was a predator. In current days, maybe that's a car coming towards us really fast. That system is going to alert us very quickly that there's some form of threat. We're going to have an increase in things like cortisol, adrenaline, and it's going to cause us to act really quickly to address that threat or run away or whatever we need to do, that fight, flight, freeze kind of response. And it's going to secrete these stress hormones. And so that can then impact the placenta's function. So it makes it less able to protect the fetus. It can cause disrupted sleep, both for a mother and the infant. And there's an increased risk of infection and chronic disease, so things like diabetes or hypertension. And I thought I'd go into a little bit of why that is. Like I said, in a healthy stress response, you're going to see that go up, and then hopefully you're going to see those hormones dissipate pretty quickly once that threat has passed and kind of return to a baseline. And if you think about it, it kind of makes sense because we want to be able to act really quickly in a state of stress. We want to be able to jump out of the way, right? We want to be able to kind of bypass our logical thinking brain and be able to respond almost automatically. And it also, that comes with some downsides though. It does shut down a lot of the systems that are, that the body considers less important during those times. So things like digestion, sleep, rest, the immune system. It kind of says, not right now, we're gonna dodge this bus or wild animal first, and then we'll put some of those back online. So it makes sense why we would see some of these in pregnancy, right? Why we would see things, a connection to things like diabetes or hypertension, why it might cause disrupted sleep, because often that stress response and that cortisol is causing some of those other systems to function less efficiently. Because it's saying, okay, we need to put all of our resources towards avoiding this threat right now. Does that make sense, everybody? So that is that's in a typical case. When we are looking at what we would call a trauma response, that's often when that stress system is activated when there is no threat, or it's dramatically out of proportion to the threat. So that's when we see that fight, flight, freeze response. People might have a lot more difficulty returning to that baseline and stay in that activated state. And a lot of times the body stays in this state of hypervigilance or kind of constantly looking for threats and seeing threats that aren't there. So a lot of times the examples people often give related to PTSD are often related to veterans, right? And hearing sounds that maybe remind them of gunfire, and then that stress response is going to activate as if a threat is there, even when there's not actually a threat present, and sometimes stays really activated. So that's what we're looking at when we talk about a trauma response, is we're seeing that same stress system happen, which is healthy when you are truly trying to avoid a stressor. It becomes very unhealthy when it stays stuck in that response, even after a threat has passed. So there are a few different, I thought I'd talk a little bit about the diagnosis piece. There's a few different diagnoses that we might be looking at if someone is meeting the level of mental health diagnosis. There's anxiety and mood disorders. These are really common during the perinatal period, and ones that we really try to keep an eye out for. There's generalized depression, generalized anxiety, depression, things like that people are pretty familiar with. Adjustment disorder is one that people are less familiar with. That kind of means what it sounds like. It means that you're struggling to adjust to something, to some form of stressor, and probably struggling to adjust outside of what we might expect in response to said stressor. There's acute stress disorder and post-traumatic stress disorder, and the main difference between those two is the timeline. So that's when we're having those out of proportion stress responses or stress responses when there isn't necessarily that trigger there still. Post-traumatic stress disorder is more long-term. Acute stress disorder often occurs right after and then resolves more quickly, which is what I'm going into here. So often when we're talking about acute stress disorder, we're talking about very often we're talking about one single traumatic incident. And so this, if I were to guess, is likely what we're looking at with the book. Common with things like natural disasters, where someone has probably been at a baseline and then something very traumatic happens and maybe they have some kind of acute stress response to it. So sometimes that's, witnessing or experiencing some form of violence. Sometimes that's something like a natural disaster or an accident, but they've mostly otherwise had a pretty baseline level of functioning, had some kind of traumatic response, and hopefully are able to kind of return to that baseline in treatment. When we talk about chronic trauma or stress, some people have started to use this term of complex PTSD, which is not in our DSM yet, but it is in the international codes that we use, so it's starting to be more recognized. And that's one where there has been long-term trauma and stress where there may not really truly be a baseline to return to, and maybe someone has faced consistent dysregulation, really consistent trauma, so often since childhood. And so that might be things that look more like chronic abuse or neglect in early childhood, chronic exposure to violence or drug use. That's when we might see more of that long-term, more complex presentation. And we might treat that a little bit differently. So I thought we could look too at some of the symptoms that we're looking at. We break it down into different categories of symptoms. So when we're looking at PTSD or acute stress, one of the categories we're looking for is intrusion symptoms. So that's this idea of unwanted thoughts or memories. So you might have upsetting memories about the event. If it was a natural disaster, right, it might be kind of persistently thinking about it. You might have nightmares, flashbacks, and that emotional distress after a reminder of the trauma. So maybe after hearing about it or hearing about something related, you might have a lot of distress, or sometimes it's a more physical response of an elevated heart rate, quicker breathing, things like that, where some of those stress responses are starting to happen physically. Another category we look at is avoidance, where people are trying to avoid any reminder of the trauma. So they try not to think about it, try to avoid any external reminder. For people who have been in a car accident, they might avoid driving, might avoid being on the road. Those are some of the things that we might look for. There's another category which is negative alterations in cognition or mood. A really common feature of this that I wish more people knew is that an inability to recall key features of the trauma is a big piece of this. So it's very common to have gaps in memory, to have difficulty recalling key moments where the brain has almost blocked some of that out. Having overly negative thoughts, maybe an exaggerated sense of blame, so maybe really strongly blaming themselves or someone else for what happened in a way that from an objective viewpoint might not seem totally fair. Decreased interest in activities and feeling having a difficulty experiencing positive affect. So they might have difficulty enjoying activities that they once enjoyed, difficulty feeling happy or feeling those more positive emotions. And the last one is alterations in arousal or reactivity. And what we call reactivity is that hypervigilance that I was talking about earlier, maybe engaging in some destructive behavior or risky behavior, irritability and aggression. Those are really common ones that we see, particularly people saying they feel super on edge or irritable and they don't know why. Difficulty concentrating, difficulty sleeping, and that heightened startle response. So you can kind of see the connection to what I was talking about earlier with the nervous system and with that stress response system of a lot of these are pretty directly related to that, right? We might have that heightened response. We might see impairment in sleep, things like sleeping and concentrating and those things that the body says, you know, that's not important right now while we're dealing with a trauma. There's also a few different presentations we can see. So like I said, acute stress is something that's going to occur immediately after a trauma. PTSD symptoms can be delayed, so you still can get a diagnosis of PTSD even months or years later it can develop. So it doesn't have to be right away. And that does happen. Sometimes people seem okay immediately afterwards, and then 6 months later, they start to have some of those symptoms that we talked about. And that definitely does happen and is not unusual at all. So PTSD is used when those symptoms are longer term, longer than 1 month, and it can become chronic, particularly if the stressor hasn't resolved, but also sometimes if those symptoms just continue for a longer period of time. We also can see a couple different types of presentations. There's one specification that's called a dissociative presentation, and dissociation is something I think has become a little bit more in the common lingo these days too. And the two things that we're looking for there are depersonalization, which is this experience of feeling like you're an outsider and you're watching what's happening, so feeling kind of detached. People describe it as like I'm watching what's happening in a movie. And there are some times, I think, in the book when the main character does talk a little bit about feeling that way, or where they're described a little bit that way. And derealization is this experience of a similar experience of distance, but it's more of a feeling of this isn't real. Like this is a dream. You know, maybe I'm separated from what's happening by a glass wall. Things seeming distorted or unreal. So those are related, but also really common experiences. So, moving a little bit into how do we actually treat trauma during pregnancy? There are a few different ways, a few different treatments that are really common. In the psychotherapy world, therapy is what I do. There's eye movement desensitization and reprocessing, or EMDR, has become a really common treatment. It's not one that I'm trained in, but it's a pretty common one. That's become well known, where they do what's called bilateral stimulation, and they'll often have the eyes moving back and forth, or something kind of tapping on alternating sides of the body, and it has a lot of evidence behind it. So I don't fully understand how it works, but I know that it is evidence-based. There's trauma-focused cognitive behavioral therapy. And CBT is a treatment that's more focused on altering the thought processes. So you're focusing on your thought patterns. You're thinking a little bit. You're focusing quite a bit on kind of changing those thoughts with the idea that is then in turn going to change your emotional experience. And then that would be what we call top-down. There's also some that we call bottom-up therapies that are more somatic therapies, more body-based, and that can include breath work, kind of doing body scans or sensation tracking, building more body awareness, and that nervous system regulation. And a lot of the reasons that these work is because Like I said earlier, when there is that trauma response, the nervous system is reacting as if that stressor is happening, and we can actually influence the nervous system in the opposite direction by focusing on some of those things that the body is trying to shut down in that moment. So if your heart rate is increasing, your breathing is going faster, things are feeling more elevated, a lot of times if we can slow that down, it can also bring some of those processes back online and kind of reverse some of what's happening. And then, of course, in some cases, medication might be appropriate. And we do have some really special consideration when we're working with pregnant people of looking really closely for perinatal or postpartum mood and anxiety disorders. And trauma is a really significant risk factor for those. So that's something that if I know that trauma is present, I might also be looking for postpartum depression or anxiety and really screening for that. All right, I thought that I would try, I was talking a little bit about some of those somatic techniques, so if you all want to try one along with me, you don't have to, but if you want to, I like to kind of talk about different techniques that I use. What I talk about with clients quite a bit is thinking of it as almost like a fire drill of the reason we do fire drills at places like schools is because in an emergency, in that moment when the stress response is happening, our brains often don't know what to do. People tend to panic and be unsure of what to do. So we practice it in a calm moment when we're not in that moment of stress so that we've rehearsed it, we know what to do, it has simple steps that we can follow. And so this is one of those techniques that I encourage people to practice ahead of time. It's really simple so that you don't have to think long and hard about it when you're in the moment. And so it's called the STOP technique, and the S stands for stop whatever you're doing. So as soon as you kind of notice that trauma response happening, stop, take a deep breath or a few deep breaths. The O is for observe. So you want to observe any kind of body sensations that you might be having. Any feelings, if you're feeling worried or anxious or happy, and observe any needs that might come up. So maybe you're thirsty, maybe you need to stretch, maybe you're feeling hungry. You're kind of observing any of those. And then the P stands for proceed, and that means proceed with something that might help in the moment. So if you identified that you need to take a sip of water, which I'll do right now. If you identified that maybe you need to move your body, if you identified that, maybe you just need a minute of quiet, you proceed with something small that's going to help in the moment. And so, like I said, this is just a small one, but I wanted to give you all something that I kind of have people practice because I think it is important to have, like I said, those tools that you can kind of rehearse and just have it at your disposal. I want to move next into some of the effects that on infants. So we talked a little bit about the impact on parents, on pregnant mothers. There's a lot of interesting research on the effects on infants as well. And I found, as I was researching this, and I had heard of this before, but there is this study on the transgenerational transmission of trauma. And this particular one was done with mothers in Africa, but there are others that are similar. And it had mothers go through moments of what they call traumatic narration, where they're having the mothers recall something that happened. So they'll talk about something, a traumatic event. And during that narration, where the mothers were describing what happened, the researchers found that they looked at infants less, they smiled less, and they had a lot more difficulty assessing the infant's emotional state. So if the infant was starting to, fuss or get upset, they would have maybe more difficulty responding to that, but also more difficulty reading what was happening with the infant. And in turn, they also found that the infants looked at the mother less and at the researchers less. and that they engaged in more self-regulating behaviors or self-soothing behaviors. So like sucking, basically trying to meet that comfort need. So there was some recognition, even in pretty young infants, that mothers were not as engaged or not as able to meet that need, which is sad, little babies. And then there's a really famous experiment that some of you probably have heard of called the still face experiment. How many folks have heard of that one? Ooh, okay, one person. It's exciting when it's new. So this is a famous experiment where they have a mother engage with an infant and talk to it, there's a back and forth communication, and they're responding to the infant's cues, playing, and then they have the mother leave. They have the mother come back and not engage with the infant at all, and just keep a still face. And it is actually really sad to watch. And the baby at first tries to re-engage in the same way. They might try to talk. They might try to reach for the mom. And typically what happens is that the infant gets more and more distressed. So as the mom just kind of sits there with that straight face, some I've seen it done too with the video where they just show like a blank video too. But and typically the infant will start fussing a little bit, and then they'll start more hard crying or screaming. And then they have the mother leave and then come back and re-engage in a positive way and go back to playing and soothe the infant and all of those things. But what was, so a lot of what this shows us, right, is that infants are relying on us as caregivers to regulate. So they don't regulate their own nervous systems well. They often are looking to their caregivers to kind of create a lot of that regulation or provide a lot of it, and that they get really distressed when they can tell that their caregiver is not attuned to them and is not paying attention to them. And so this is a very famous study, and they recreated this famous still face experiment study with mothers who had PTSD. And what I found interesting was the mothers with PTSD, the infants showed higher levels of that hard crying throughout the course of the experiment. So they went a little bit quicker to that hard crying past the fussing stage and were crying harder throughout. And this I found super interesting. Their greatest distress was actually during the reunion episode. So that should have been the recovery stage when the infant's like, oh, okay, phew, you're back, right? Well, like I can regulate and soothe again. And that was actually when they started crying more. Which I think shows that there's more distress, but also more, I would guess, more unpredictability, or more like, okay, is mom going to engage with me or not, right? And that they're maybe used to a level of engagement that feels more inconsistent. And the infants also had more difficulty accepting those soothing behaviors from mom, so more difficult to soothe. Didn't always want to necessarily, like in a typical scenario, you would see infants be soothed pretty quickly, and they had a lot more difficulty kind of accepting that soothing behavior when the mothers had PTSD. So I found that, like I said, that this can have quite a bit of impact on infants. So when mom is in that state. So a few thoughts on, now that we kind of have all of that knowledge too, on how we can support new moms or anyone who's maybe gone through some kind of trauma. Just being able to listen non-judgmentally, being able to offer patience, learning more about PTSD and its impacts like we did here, and being aware of specific situations that may trigger symptoms. I think this is an important one that is often overlooked, is if you do know someone in your personal life who's been through some kind of traumatic event, being able to know, okay, maybe this particular situation is likely to cause some kind of symptoms or some reaction, and so I can be aware of that and maybe help them through it, help them maybe avoid that if that's what's needed at that time. And then being able to encourage more positive activities or distractions, maybe to engage into activities that they typically enjoy. So if I were in the book, right, like I might want to be encouraging maybe some of those fun activities that they did together, right, or like maybe not taking walks in this case because she walked a lot, but having some kind of a positive, something that they already have that maybe positive association with. And a few ideas of what we can do, just being able to recognize and treat trauma, being able to improve screening and screen earlier. This is one that I really try to push for, is just a lot of people are not necessarily, it's becoming much more common, but aren't necessarily as trained to recognize and screen for trauma. And people don't always necessarily bring it up. I found that a lot of the clients that I work with, if I just ask, have you experienced something traumatic? A lot of times they'll say no. And then as we dig into things, you've actually experienced many traumatic events, right? But people don't always recognize it as such. So being able to improve screening and being able to ask questions that kind of get into what may have happened to them. Recognizing disparities and inequalities. This is one that I got into. I meant to kind of reference on a different slide, but in talking about kind of that prevalence being different in different populations, just being able to recognize that and be aware of that as we're treating people as well. And obviously prevention when possible. We can't prevent every trauma, can't necessarily prevent a natural disaster, but if it is possible to do so. I have some resources, and I know they're hard to read, but the articles that I referenced. There's a few other great resources. 0 to 3 is one of my favorites. There's the National Childhood Traumatic Stress Network. Those two are more specific for like kind of the 0 to 3 or birth to 6, but have a lot of resources for both providers and just people in the community. And then specific to new parents, there's Postpartum Support International. They have a helpline and a lot of great resources and, again, trainings for professionals. And Baby Blues Connection is a local nonprofit that supports new parents. And so they also have some support groups. They help people connect to resources, things like that. And I got through this way quicker than when I practiced because I tend to talk quickly when I am in front of people. So I'm happy to answer questions. I'm happy to talk more, whatever would be most helpful. Okay, good. It's not just me. Yes.
But if you have questions, we'll ask them with the microphone so that our audience online will be able to hear your question. Does anybody have questions?
So when you think about what happened in the book, I mean, first of all, this woman has a building fall on her, and then she's out and she runs into a woman who was seriously injured on her bike, and then she discovers that her husband, who said he was going to be in a particular location, wasn't, and he had lied to her about something that was important to her. And then she hears the words that the part of town that he was in, where he wasn't supposed to be, was kind of flattened. And then she was walking home and had a baby. So,
Yeah.
Is that just one trauma, or how is that like 5 traumas?
Yeah, that is a really good question. I mean, it could be considered either way. It definitely could be considered and I don't know that it would necessarily matter to me either. I think I would more want to know if she perceives that as one big trauma or multiple, because I could see that, right? There's a betrayal. There's probably a feeling of betrayal there. There's birth trauma. There's natural disaster, right? And so I think there likely are multiple there, but from the way I approach things, I tend to go off of how my clients are experiencing things and how they're describing it. So if they're describing that as multiple traumas, I probably would treat it as such. And if they are saying, well, this was all one just horrible day, I probably would go with that. So kind of leading by how the person experienced it.
So I suppose, she could have things like where something happens, it's just one piece of that, and she could have just a trauma response to that one thing.
Yeah, and it's not always predictable. Sometimes people respond to, there's something that is very traumatic that happens and people feel like, well, actually the part of that was the hardest, or that I'm having big trauma responses is, right, maybe not being able to find her husband. And for another person, it might be the birth piece, right? So I think that's very dependent on the person too. Some people can have very traumatic experiences and not have some of the symptoms that I talked about. So I think trauma is it's all very relative. I heard it once described as a wave, and that, like, if you think about, it basically is like whenever trauma kind of happens, whenever our resources are not able to keep up with the demands of a situation. And so thinking of it as like, the same wave might knock down a toddler, but to a grown, to a 6 foot tall man, it might just barely brush their kneecaps and they might not notice it at all, right? And I think it's similar with people. There might be some things that don't register strongly with people that can completely disarm someone else.
Yeah, thank you.
Any other questions? Oh, Lena.
So a quick question about cortisol. That's produced in the body, right? Is it a
Yes.
hormone? And what gland produces that? And it's a reaction to stress.
It's a
right?
reaction to stress. Yeah, it is a hormone. There probably would be a doctor out there who would correct me on some of the anatomy, but my understanding it's the HPA axis, so the hypothalamic pituitary
In the brain.
adrenal. So yes.
Oh, okay, okay.
Yeah.
And then second question, that eye movement therapy. So it's just moving the eyes. It's not directing it to something positive. It's just totally moving the eyes, and that kind of alleviates the
They
stress?
typically, again, this is not a model I'm trained in either, so someone who is might correct me on this too. They do move someone through some form of traumatic memory or experience during that time. So the idea is that they're reprocessing it. So they would be talking about or thinking about that particular traumatic moment, but they aren't necessarily like redirecting to something more positive. That would be more similar to what CBT would do, where they might redirect the thought process, but the eye movement one is more just focused on the eye movement and then reprocessing.
That's
yeah,
really
it's
curious.
fascinating.
Yeah. Then the third thing, that still face experiment, was that actually with mothers who had PTSD, or it was just trying to get info about how this affects the baby? So any mother was involved in that, or was it?
So both. There's a very famous experiment that was done just generally with mothers and babies, and then the one that was specific to PTSD was copying that and kind of redoing it, looking specifically at mothers with PTSD. So both, yeah.
Because I think doing that to a child would be kind of cruel, you know?
Yeah, and it's pretty. It is. There are some ethical pieces around that for
Yeah,
sure, which is
yeah.
why they have. It's pretty short. And it's also why they have the mother then immediately come back and soothe the infant too.
I mean,
So it's not a prolonged. They don't, we're talking like a minute, right? But yes, I agree with you. That's why they keep it to a short
I mean, I can
time.
see it as a protocol or an intervention for
Yeah.
a mother who has PTSD, but just a normal mom and baby, it just seems kind of like a cruel thing to do. But maybe the information garnered can be applied to other situations.
Yeah.
I don't know.
I haven't read the book, but I just popped in. But piggybacking on that question about with the children, if they're in that type of situation, have they done studies like how that affects them with the lack of response, like more in a chronic situation, like with the kid developmentally, how they learn to deal with things if their mother is stressed out and traumatized and not responding like maybe someone who wasn't?
Yeah, that's a good question. I don't know off the top of my head of specific studies that I could reference to cite that, but I do know kind of some of the general research I referenced in the very beginning, and then of kids having more long-term mental health impacts. So my guess would be that yes, there would be longer-term difficulties with emotional regulation, difficulties with maybe more anger or irritability or some of those things that I talked about. So I would guess that would be very likely be the case. I wouldn't say doomed, but
What types of screening tools do you use on these newborns born of traumatic circumstances?
yeah, that's a great question. There's a few. There are a few that we have. There are a couple, and I'm trying to think off the top of my head. There's a child behavior checklist. There's a trauma screening inventory that's specific to young kids, and it's the parents filling these out or caregivers. Obviously, a 3-year-old isn't filling out these screening checklists, but there are a few that are validated and that have been studied, and typically they're in kind of a checklist format that's either looking at the behaviors that are shown or particular symptoms that might be shown related to trauma. Yeah.
Well, speaking of the child trauma, so you do the best you can while the child is very small and try to get them whatever treatment they need, but is there any correlation between what you see and identify as trauma and then what an older child, like a 5 or 6-year-old, may say was traumatic to them?
Yeah, that's a really good question too. And those, like I said, sometimes those are hard to separate between parent and child because sometimes what the child's reacting to is more so the parent's reaction to something. But I would say absolutely. I've worked with really young kids who have experienced events that they would call traumatic. They don't always use that language, but a lot of times what I'm looking for is how they play, how they interact, whether they look to, when we're looking at attachment, I'm also looking for how they look to their caregivers for support or for comfort. So are they, when if they fall down and trip, right, are they looking right to the parent that's in the room? Do they just kind of move on because they don't expect that someone's going to comfort them, right? Do they get like really, really upset and can't be soothed? So I'm looking for those kinds of things. But yeah, absolutely. And the method I'm trained in of child-parent psychotherapy is really specific to parents and children, young children and parents who have gone through a traumatic event. And often I'm really treating them both simultaneously, even though the focus is on the child.
So you were mentioning if a parent and a child experience trauma, how do you treat a little kid, like a toddler or early grade school, like because you can't get into these intellectual conversations probably, and
yes. Yeah, that is an excellent question. And I do get asked that a lot because I have worked with really young kids, even infants and toddlers. So a lot of times so there is play therapy, which often does work for 2 to 3 and up. And that involves playing. The child we're using the theory that play is essentially a child's language. And so they may be playing out a certain scenario. They may be working through something in play that they can't express in language. For kids even younger than that, and oftentimes for the preschool age too, what we're doing even though we're treating a child, we're working with a parent and caregiver together, and we're working on improving that attachment relationship and improving the parent's attunement to the child. So there's quite a bit of caregiver involvement. It isn't just, sitting a toddler on a couch, but there is a lot of that parent and child together in the room, and maybe I'm kind of giving the parent a lot of cues of, okay, look, the kid is wanting to engage with you in this way, and I'm kind of working with them on improving that relationship and improving their ability to react and respond to their child in a way that's going to be helpful in the long term.
Have you ever tried sign language with young kids because they can express things in sign language before they have the fine motor skills to verbalize? Is that a protocol that could work?
That's a good question. I don't know on a professional level. On a personal level, I learned the baby signs with my own kids, and there's absolutely a lot to that. I've never heard of that in the therapy context, though, so I would be curious if there was something.
It seems like it would work.
Yeah.
I taught the deaf for 10 years, and children can make signs and express themselves at a pretty young age.
Absolutely.
Through sign language.
Mm-hmm. Mm-hmm. Yeah, that would be really interesting to study and explore more. I want someone to do that research. Oh, there's one more.
Could you tell me more about the process of treating like the child with the trauma and like I don't know, I'm just like really interested in that part specifically.
Yeah, absolutely. Yeah, so a lot of times what I'm doing is kind of looking for maybe those emotional responses that I'm seeing as maybe being related to trauma. And a lot of times I'm kind of helping parents to attune to that. So it's really common, for example, for parents to view that negatively of like, oh, they're just being bad, or they just don't like me or whatever. And so I'm a lot of it is providing some of that education to parents around, well, actually, when this is happening, they might be looking to you for more support, or they might just be so dysregulated that they can't calm themselves down. And so I'm kind of coaching the parents through those moments. And a lot of times with really young kids, I'm also maybe allowing them to engage in whatever they need to. So maybe that's some form of play that they're using to express what happened. I've definitely seen kids in play therapy that will kind of act out a traumatic event that happened. Sometimes I might be, helping the parent and child do something together that's helping them both regulate, or involve some kind of breathing, like blowing bubbles or things like that. So it depends. It can look a lot of different ways, but a lot of times that's doing a lot of what I'm doing is really coaching the parent on attuning to what's going on with the child and kind of watching for the kids' cues at the same time of what they're looking for, what they might be needing. And I almost think of it like translating a little bit for the parent of like, you might be perceiving this in one way, but I'm kind of translating that into language that the parent can understand. Does that make sense? Did that help?
I forgot what I was going to say.
That's okay. If you think of it, come back.
So that was, it sounded like a little bit more of like the child experienced a traumatic event that they can recall and recount. But in the beginning, you were talking about like when it happens when they're in utero, and it's the stress and the hormones, maybe getting across the, placenta, or
Yes.
and somehow affecting the brain development of the baby.
Yes. That's a really good question. And I have in the past actually done groups. I've done some therapy groups with moms with newborns that either have been, some that were in drug and alcohol treatment, and some that were had been through a domestic violence situation. And so a lot of times what that looks like is similar to what I said just in the last question about helping those parents to read those cues. It was really common in those groups for them to perceive the child much more negatively, I think, than maybe a typical mom who has not been through a traumatic event might. And so a lot of times it was some of that negative cognition that I talked about, like my baby doesn't like me. They cry when I hold them. They don't want me around. And so a lot of times it was working. You are working with the infant. You are working with them too. But a lot of it truly was working with those moms as well, of like being aware of maybe why the infant's having that response. And helping them work through it, and helping them to maybe perceive it much more positively, or really encouraging them of like they want this response from you, or they want to be around you, or they want to be held by you, and really working with them. A lot of times, it looked a lot at times like the library story times that we'll have where we're like singing and reading books and doing a lot of those bonding activities. It just was a little bit more specially focused on really helping the parent attune to a child's regulation and to their state. And so we might be like checking in on that of like, oh, look, they just looked at you, and like really highlighting and really pointing out those positive moments. So it looks very different from what people think of as therapy, but it is really highlighting that attachment piece. Does that make sense?
Well, it does, because the trauma was while they were forming,
yeah,
right, and their brain was forming, but brains are so plastic,
yes,
neuroplasticity, especially little tiny ones, that if you have this intervention, you can almost maybe try and map some of that stuff out, so
yeah,
you don't have this, Yeah.
Yeah, you can, because a lot of what we're looking at for, a lot of what we're seeing is that that dysregulation, that may be like crying more than normal, that difficulty, looking at or tracking mom, and so we're really like pinpointing those, and I'm like laser focused on looking for those moments of like, oh, they looked at you, and then like kind of cueing mom to really engage with that, and the more that happens, the more the baby has that pattern of healthy attachment and, oh, I want to seek out mom for comfort, versus the opposite response of like, well, I cried and mom kind of, sat there still faced and didn't really know how to respond to me, right? Like that's creating the opposite pathway of what we want. So, yeah.
So when you're observing the mom who maybe experienced a traumatic event, how she's mothering, do you think that's something she's learned relationally, maybe as a kid herself, or also how trauma affects you physiologically?
Yeah.
Is it like a combination thing, like that she would see her child as crying as a negative, like kind of thing? Like I'm just curious, what would make those people who experience trauma react that way versus quote, quote, maybe a normal reaction to your kid wanting to get comforted or whatever?
Yes. Yeah, that's a great question. And I really want to reiterate too that I think it's very common for there to have already been, maybe some negative childhood experiences or things like that are playing into the mix too. And I never ever want it to come across as this is the mom's fault or anything like that, because I don't believe that that's true, or that they're not mothering correctly or any of those things. I don't want that to be the message. I think a lot of times that's coming from that negative cognition that I talked about of like misattributing blame, maybe either to themselves or even in some cases to a baby. Sometimes the stress of I think honestly sometimes the stress of crying is just if their own nervous system is already very dysregulated, it can shut down, I think, much more easily than someone that hasn't experienced trauma. And so that crying just, it kind of becomes a vicious cycle where it's like, I don't know how to deal with this baby crying, and it's upsetting, and because it's stressful. If any of you have children, it's stressful no matter what. And I think it's even sometimes at a heightened level when someone's been through trauma. And then that kind of gets reinforced, right?
If a child has some early trauma as a baby, and they don't get any help, and so the parent's reaction, the baby and the parent are working well together. When you see them when they're older and they can talk, can you go back and figure any of that out, or do you just deal with what's going on in the relationship now?
That's a good question. I mean, I do try to deal with what's happening now, but I do always try to ask about those early childhood experiences of, what was a kid's early childhood like? What was their process of, how did they sleep and toilet train and meet milestones and all of those things. And I kind of like to ask a lot about a kid's temperament and the relationship and any traumatic events that have happened. So I would say it might inform the way I'm thinking. I don't necessarily go back and talk about it if they're not, bringing it up, but I likely will incorporate that in some way or bring up, you all maybe missed out on some opportunities when you were younger, and so we might try to recreate that. It kind of depends a lot on the kid and the parent and where their skills and willingness are, especially because as kids get older, they have more and more agency in treatment, and so I'm doing, I think, less and less of kind of creating that for them, right? Like they're coming in with more that they might want to work on. So it depends a lot, but yeah, I would definitely try to consider that and ask about that. Absolutely.
So just one more question. Is your job satisfying? Do you see that you make a difference with a baby, or?
Yeah, honestly, I do. And I don't work a lot with babies anymore, but some of my favorite work has been with parents and infants. I absolutely love that work. So it is satisfying. You don't always see, a lot of times it's long term, like you don't always necessarily see it, see things play out, but there's always that hope that it does. And sometimes you do. Sometimes people come back and, they're like, oh, this made a difference. But yeah, I mean, I do think it's satisfying. Yeah. It's a good question.
So I actually had a couple questions, and one of them was when you talked about how the parent's reaction to an event kind of determines how the baby reacts to it as well. I was wondering if the opposite kind of plays a part, because you mentioned that that the baby, when you're doing the therapy, might look to the parent for comfort or for a reaction. And if they didn't give them that reaction, that would kind of build a gap between them. So I was just wondering, God, I forgot my question again. But I guess I was really interested in how a parent's modeling behavior changes, maybe a baby's resilience or how they respond to certain events like trauma. Something bad could happen, but if the parent doesn't show that it's traumatic for them, will that not be the traumatic for the baby as well?
That's a good question. I think I wouldn't necessarily want to shut parents down in terms of don't show any reaction or don't show any emotion, because I think what I'm ideally looking for long term is that a baby has, over the long term, gains the ability to experience distress and then learn to resolve that and tolerate it, right? And where they can have these ups and downs, and it doesn't go, okay, I'm distressed and then I'm stuck here, right? And that, I think, is sometimes the risk that can happen. And so I guess I'm looking for those opportunities to practice that. And I think sometimes how do I want to answer this? I think sometimes there are, if you've ever seen a toddler fall down and then they most parents have had this experience. They look to the parent, right? And then if the parent just doesn't really see it, they'll get up and walk away. But if the parent's oh no, are you okay? Right? They start sobbing and crying, right? So I'm not saying that's I think that's one example that a lot of people have experienced personally. And I think that's kind of what I mean when I say we want to see kids knowing that if they look, right, if they look to their caregiver, if they truly are distressed, right, that they are going to be comforted, right? But I think they also are at the same time they're kind of watching for the response that their caregiver is going to get. And if the caregiver gives a response that's really elevated, oh no, oh my gosh, right, the kid is going to perceive, oh, this was really bad, right? This really scared my parent or caregiver. And so we want to kind of balance a little bit, right, of not overreacting and not underreacting. We don't want to give such a big response that the kid is picking up on, oh, this is something really scary, but we don't want to under-respond where the kid doesn't want to come to us when they're scared or upset too. It's a kind of a complicated answer, but hopefully that helped.
That was helpful. I do ABA therapy with 3 to 5 5-year-old autistic children, and a lot of the time we do see those reactions where they're looking for reinforcement when it's something that's not a big deal, but reflecting your reaction to something, I was wondering is it a good idea to reflect their emotions, and would that communicate that you are there for them more, or would it be better to model what you would want them to do?
Yeah, that's a good question. I think that depends so much on the kid, because kids are can be so different. So I would read the kid in the situation, but yeah, sometimes I would just give that acknowledgement of oh, I see you, and you you fell down, and you're okay, right? If I do feel they're okay, and so I that way I'm still kind of acknowledging it and acknowledging what I'm seeing and what they're doing, or oh, you're wondering how I'm going to react, right? You're wondering what I'm going to say. So I might kind of acknowledge that. With some kids who I know they don't, if it's if I know that they tend to underreact, I might like check in more, right? I might be more like, oh, do you want a hug? Do you want something, right? If I know that they struggle maybe to ask for that. So it depends a lot on the kid.
Sounds like a really hard job. Yeah.
Yeah, yours too. Yeah,
Thank you.
absolutely.
And then, sorry, one last question. So are there any patterns in play behavior that you think like are connected to trauma besides like acting out the trauma itself when they play? Is there any other thing that you think is really connected?
Yeah, I'd say like really disorganized play or like sometimes super repetitive play. Although if you do ABA, that can sometimes be part of autism too. But I would say, yeah, sometimes really repetitive play where they're really stuck just playing the same scenario over and over and over and over again. I've worked with kids like that. Yeah, sometimes if it's super disorganized or destructive, where like all they want to do is like have the dinosaur smash everything in the room, right? Like, so those are some that I look for. Again, you kind of have to, it's very dependent on the kid too. I think I don't want to necessarily give a blanket statement that if I see that, that means there's trauma, but because it would depend a lot on the scenario. But yeah, I'm often looking for like, is the play, kind of what I'm looking for, maybe particular themes. Sometimes kids that have been through trauma want a lot of that like nurturing play where they're like taking care of a baby doll, or they want me to really like take care of a baby doll. So it can manifest in a lot of different ways, but I'm kind of looking at the overall themes. Are they able to kind of stick with play that looks pretty developmentally typical, or with some kids if it really looks very atypical, like I said, where they're not really even playing with anything, but they're just kind of like dumping stuff out and like smashing, and then I'm like, okay, what's happening there that they're not like engaging in a way that a typical maybe 2 or 3 year old would.
And that's what disorganized play is?
I think that's how I would define it. Yeah.
Okay, thank you so much.
Yeah, of course. I'm sure there's a better definition out there somewhere if I were to look it up. But
well, Kaylee, this has been absolutely fascinating, and we still have a little time before closing. So if you have questions that you want to ask privately, I think Kaylee could stay for a minute or two. But can we give her a big round of applause?
Thank you for asking such great questions too.
They were great questions. Clearly, you engaged everybody. Great. Thank you.